Hello, everyone, and welcome to this St Anne's College event. We're really delighted that so many of you can join us. We know that many of you are in Hong Kong, either alumni of the college or members or family members of students who are currently attending the summer school, which is happening for the fourth time for Hong Kong school students. It's the first time we've done it online, but we're delighted that the event is able to go ahead this year, having had to postpone it from last year. The Hong Kong Summer School is something that we've enjoyed doing on a number of occasions now, and we're very grateful to our alumnus Bernard Mann and to Patrick Hume for the financial support that they give us to deliver that programme. So for those of you who are alumni of St Anne's College, you may have been wondering what the last 18 months has been like for us, for our academics and for our students. And of course, it's been a tough and difficult time with large lectures happening online, with teaching often having to happen online as well. And often our students scattered around the globe where they haven't been able to return to Oxford. So in this last term, Trinity term, the summer term, more students have been present, and we've been able to relax some of the restrictions to enable college life to be not entirely like normal, but more sociable and more opportunities to mix and meet each other. And largely it's been a successful term, people working very hard to prepare for exams and to submit dissertations. And largely we remained COVID-free, although right at the end of term, we did have a number of cases which did disrupt individuals' plans. But we're really proud of the way our academics, tutors, researchers, students and staff have responded over the pandemic with all its changes, with all its uncertainties and all the worries about how it's affecting everybody's lives. And we've been so appreciative of the support that we've received, moral support and financial support, that has enabled us to bolster our teaching, because of course many of our students have missed out on some of their schooling because of schools closing due to the pandemic. And also the finance has really helped in terms of us being able to support students' mental health needs. This has been a very stressful time for everyone. And for a number of our students, it's created financial hardship with difficulties in their families. And for our international students in particular, it's caused a number of them to be in some very difficult financial situations. So we're delighted that we've been able to support them all to continue their studies and continue to make the most of their time in Oxford. And we hope that those of you who were students at the college have many happy memories of the time that you spent in Oxford, the relationships and friendships that you built, and how your degree and your time prepared you for the lives that you've been living since. So thank you for that support. It means a huge amount. Today, we're delighted to be able to welcome our guest speaker. And not so much a guest really, because Zoi is so much part of the college herself. Zoi is a lecturer in medical sciences at St Anne's, having studied at the college herself, both for her original medical degree and also for her doctorate. She's also very actively involved in the Centre of Personalised Medicine, which is a joint venture between St Anne's College and the university's Wellcome Trust Centre for Human Genetics. She's a neurologist and a neuroscientist, and her expertise is in pathophysiology and new drug development in neurodegenerative diseases, including Parkinson's and Alzheimer's. And Alzheimer's is what she's going to be speaking about today, which I know is an important topic to so many of us who have family members and others who are affected by this disease. She's an Associate Fellow of the Higher Education Academy and was awarded a commendation in their Teaching Excellence Awards in 2017. She's also won multiple academic awards for her research, and we're very proud of her association with the college. Our students on our summer school are also very lucky that Zoi is one of the tutors participating in the teaching this week on that. So we're thrilled that she's joining us today to speak on this important topic. As well as hearing from Zoi, I know that she's very kindly agreed to answer any questions that you may have. We've had a slight technical hitch with Teams, so we want to ask you to email your questions in as Zoi speaks or at the end of her talk to the email address which is on the screen now, which is development.events@ox.ac.uk. And then from the questions, I'll ask them to Zoi when she's finished her presentation. But we're delighted that you can join us today. And I know that you're going to find what Zoi has to say absolutely fascinating. So I'll hand over to her now. Thank you.
Thank you very much. And it's a pleasure to get the chance to talk to you today about a topic that I'm passionate about, Alzheimer's disease, and I'm even happier that I can do that to alumni of the college. And thanks, Helen, I truly feel St. Anne's to be my home, and it's like a family to me. I've spent years here, and I am really fond of what this college represents, and all the people who are supporting it and leading it as well. So with that, I am going to share my screen. Can you see my presentation? Not yet. Okay. Share. Sorry about that. What about now? No. Okay. Do we? Okay. All right. Thanks. So next slide, please. So I'm going to start with the impact of Alzheimer's disease. So we all know it is a disease that affects a large amount of the population, especially nowadays with an aging population, since medicine has improved and found treatments for so many age-related diseases. The average life generally globally, the age of people who start presenting with Alzheimer's becomes more and more important, and as you can see in this table, people over 85 years old have a significant chance of developing dementia. It's nearly one quarter of the population. So it means that we have a pressing urge to find cure for Alzheimer's disease and other neurodegenerative conditions. So as we know, Alzheimer's is the commonest out of those neurodegenerative conditions, and it is one of the most debilitating for the patients, starting with forgetting things, and then this becomes more and more functionally debilitating for the patient. So next slide, please. As you can see here, the duration of the disease can range from 5 to 20 years to progress. Some cases progress quicker, but some are more long-standing. And the participants, as we go down the line, they become more and more debilitating with issues such as incontinence, motor abnormalities, problems with feeding, and then they end up being bedridden if they reach that end stage of Alzheimer's. Next slide, please. Currently, we have no treatment for Alzheimer's that could stop the disease or even slow it down. And we are going to discuss today why we have reached that end, this challenging condition, and whether there is light at the end of the tunnel, and if this new approval from the FDA at the beginning of June of Ajikanumab is the end of the tunnel or not. So currently, all the disease, all the therapies used for Alzheimer's are symptomatic therapies. So the acetylcholinesterase inhibitors only give a 3-month cognitive boost to patients, but they don't change the disease progression. Next slide, please. And as you can see here, the yellow line is the natural history of disease, or if we don't give any treatment to the participant, and the quality of life decreases with time passing. The red line is what the effect that we get from the symptomatic treatment, which basically boosts cognition for 3 months. But as you can see, the slope of the line doesn't change significantly from the yellow line, so it doesn't alter the progression of the disease. Ideally, in an ideal world, we would like something like the green line, where we arrest the progression of the disease, whereas in a more realistic approach, we would prefer something like the blue line, where we decelerate the progression of the disease. And this is what we're most likely looking at as a best case scenario. Next slide, please. So in order to understand what we will need to come up with a disease-modifying treatment, we need to understand what are the brain changes in Alzheimer's disease. So pathognomically, we know that we need amyloid accumulation in the brain in order for someone to be classed as a patient with Alzheimer's disease. So amyloid is a protein that becomes sticky and aggregates in the brains of Alzheimer's patients, and it starts its aggregation by clumping into oligomers, then protofibrils, which are really toxic, and then fibrils and aggregates, forming plaques between the neurons in the brain. Another protein of interest is the tau protein, and this forms aggregation, but this time inside the neurons. So with amyloid and tau accumulation in the brain, that both of them happen in Alzheimer's disease, the neurons become dysfunctional, and thus the patient starts forgetting things, and then the defects become more generalized. Other elements of pathology in Alzheimer's are neuroinflammation, so inflammation in the brain, where microglia play a critical role in the development not just of Alzheimer's, but also of Parkinson's and other neurodegenerative diseases. And there is evidence of vascular change in some participants, in some patients, but more importantly, there is a neuronal and synaptic loss as a result. Next slide, please. So a critical question to ask is, when does Alzheimer's start? So as you can see in the first figure here, we have a PET scan showing amyloid in genetic cases of Alzheimer's disease. And you can see that from 20 years prior to initiation of symptoms, we have start of accumulation of amyloid in the brain, which means that we have a big time frame that we can pick up the disease in early on in order to start altering its progression. So we need to actually be able to pick up those patients early, even before they come to the clinic with memory problems. And you can see very importantly in the graph below, the first thing that you notice in those participants is a change in the amyloid positivity in the brain. So normally the amyloid scans are negative. However, it turns positive in people with Alzheimer's disease, which is followed by tau accumulation in the brain, the orange line. And then the MRI changes come next. So the volume of the brain starts decreasing. The next change is when the cognition starts failing, and this is the first time that you pick up the patients in the clinic. And the last one would be the functional decline that the patient has. So you see there are so many steps prior to the patient presenting to clinic with the memory problems that we can intervene and that we can pick up patients at different stages. And this is crucial because if each participant presents into different stages, we might be able to intervene with different modalities according to which stage they present at. So in the future, it will be really exciting to see to actually stratify the patients according to their molecular characteristics. Next slide, please. Okay, so we talked about the amyloid and tau that accumulate in the brain, and I kind of make a joke, the Taoists or the Baptists. Basically, the two different schools of thought. Firstly, people who support amyloid as the cause of Alzheimer's disease, they do so because of the amyloid cascade hypothesis and all the familial mutations that are guaranteed to get you Alzheimer's disease if you do have them, and people with Down syndrome that have a significantly increased risk of getting Alzheimer's disease due to the triplication of the chromosome, which includes amyloid. On the other hand, the people who support the tau hypothesis do so because the progression of tau in the brain correlates much better with the cognitive impairment of the patients rather than the amyloid progression in the brain. Next slide, please. So you can see here in the first image, stages 1 or 2 of Alzheimer's disease, the tau accumulation starts in the transentorhinal area when it's clinically silent, but then it starts spreading into the limbic system, and then as it spreads in the neocortical or the full cortical area, the patient has a fully developed Alzheimer's disease. So this progression actually correlates very well with the symptomatology of the patient. However, the unifying theory supports that the aggregation of amyloid facilitates the aggregation of tau, and as a result, there is neurodegeneration and thus dementia. So there is a sequential effect rather than one or the other alone. And as you can see here, we start thinking about how we could target tau or amyloid in order to stop the progression, and we can either decrease its expression, alter its splicing, or stop its phosphorylation because phosphorylated tau is much more detrimental than normal tau protein, and as a result, that could have an impact on the aggregation and spread of tau in the brain. Next slide, please. So this leaves us with many options on what to target in the brain. Some of the avenues we can go down is either try to decrease the production of amyloid beta, either to try to prevent the aggregation into oligomers and aggregates, or prevent the spreading. We can also try to remove the amyloid or the tau from the brain that has already accumulated. We can either try to inhibit the phosphorylation of tau, or take altogether some alternative approaches, such as decreasing the inflammation in the brain, or try to increase synaptogenesis, or increase neurogenesis altogether. So there are so many avenues that we can go down. Next slide, please. So here this is from a few years ago, but you can see that like how many drugs have been in development for Alzheimer's disease, and yet we just got one out of those to be approved by the FDA in June. So why have we had so many failures? Next slide, please. Some of the failures have been in therapies against amyloid, and the agent that has been approved just now from the FDA is one of them. Initially, Ajikanumab, initially it was thought a failure, and then it took approval, and we'll see how that happened. Some anti-tau antibodies also have failed clinical trials, and some agents trying to prevent the increase of amyloid also have failed. Next slide, please. So why is it so difficult? Why have all the clinical trials failed? Is it that we have no effect on the targets that we are proposing, like on amyloid or tau? Is it that we use the wrong dose? Is it that we have the wrong target in mind altogether? Is it that we intervene too late in the disease process and we can't change the pathology after that? Or is it because we don't have well-validated biomarkers to pick up participants early or even stratify them for our clinical trials? Next slide, please. So the truth is, we still don't understand the mechanism 100%. The animal models aren't very helpful, simply because animals don't get Alzheimer's. So the majority of the models we're using are trying to mimic elements of the disease, however, not the entirety of the disease. The populations that have been taking part in clinical trials were very heterogeneous. Even the first clinical trials in Alzheimer's disease, they didn't even check for the presence of amyloid in the brain. And it was normal back then because they didn't have the means to, they didn't have PET scans to check for the presence of amyloid. However, that would guarantee a failure of the trial because it would include participants with vascular dementia, not Alzheimer's disease at all in the trial. Another element is what are we measuring in the clinical trial as a change? Is that scale clinically meaningful, and does it actually pick up small differences over time? The clinical trials in Alzheimer's are very long trials. You need to wait a long time before you pick up a change, even with a disease-modifying medication. And also, what are we trying to measure as a difference? Is it a difference between drug we're testing and placebo, or in preclinical trials before the patients, the participants start having symptoms? Is it a delay to when people start having cognitive impairment? Next slide, please. So as you can see here, we have different scales to measure change in Alzheimer's trials. We can measure changes in cognition. We can measure changes in function or behavior. The registrational endpoint for the FDA and EMA, European Medical Agency, so far has been a CDR sum of boxes, which measures both cognition and function. However, this is really insensitive to changes over short periods of time. So you need to wait 2 or 3 years to find a meaningful change, and this can be difficult in clinical trials. Next slide, please. And as a result, there was an urgent need to find biomarkers for picking up not just people and patients early, even before they present to the clinic, but also trying to identify changes within the clinical trial. So, for example, a patient who would be amyloid positive, turning amyloid negative with amyloid lowering therapies in the clinic. Next slide, please. And as a result, in the future, it could be that we target different, using those biomarkers like amyloid PET and tau PET scans, to pick up patients in different stages of disease and treat them with different medications and have a different aim, like secondary prevention or primary prevention. Next slide, please. So we're going to talk about the news that came out on the 7th of June, so very recently, by the FDA, who granted accelerated approval for an Alzheimer's drug called Ajikanumab, or Aduhelm. That was from Biogen. Next slide, please. So this first hit the news back in 2016 in this Nature paper, where it showed that Ajikanumab was able to reduce the amyloid levels in the brains of Alzheimer's disease patients using the amyloid PET scans. And this was very promising at the time that it could actually slow down the disease. Next slide, please. So in order for, I'll get you through this clinical trials schedule of Ajikanumab, just so you can understand why there has been a huge debate in the area of Alzheimer's disease since this approval, and for us to understand whether this approval is meaningful or if it's just the light at the end of the tunnel. So Biogen performed 3 phases as it's done in clinical trials. Phase 1, the phase 2 was study 103, and it's imperative for FDA approval that all pharmaceutical companies run 2 pivotal phase 3 studies, 2 sister studies, if you wish, in order to get registration. So Biogen performed 2 sister studies, study 301 and 302. One was in the US and the other one was in Europe and rest of the world. And essentially there were sister studies, everything was the same, apart from the study start and the different geography of those. Next slide, please. So the phase 3 trials, again, were multinationally, internationally done. These were 18-month trials, placebo-controlled phase 3 studies. They would have enrolled 3,285 patients, so a large number of patients. And the population to be studied would be early Alzheimer's disease, but not preclinical. So once the patients started having mild cognitive impairment and also mild Alzheimer's disease. They had 2 dosing regimens, so low dose and high dose, and also placebo. As we said, the endpoint was CDR sum of boxes that was at 18 months. And they also had some secondary endpoints. Next slide, please. The medication was given intravenously because it is an antibody, and it was infused once a month in the study sites. And there was a 24-week titration to reduce the incidence of side effects from the medication, and specifically for amyloid-reducing agents, we are worried for what we call ARIA. Next slide, please. So when you remove amyloid from the brain, you have increased cerebrovascular permeability, and as a result, you can get either edema, called ARIA-E, or some small hemorrhages, microhemorrhages, ARIA-H. So this, they start being, in the majority of cases, asymptomatic, so the patient doesn't even know it's happening. You can pick it up with an MRI scan, but in some cases it can present with confusion or headaches, and the patient is followed up with more MRI scans. If the edema or the hemorrhages are small, and small in number as well, the participant is continuing in the study. However, if the patient is symptomatic, or if the edema is large, or the hemorrhages are multiple, then the participant should stop dosing until they are resolved. So as a result, this means that someone who was on Ajikanumab needed to be followed up with sequential MRI scans throughout the trial. Next slide, please. One more, please. Great. So the results from these two trials were discordant with each other. So if you remember, there were two sister trials, one in the US, one in Europe. And you can see in the study called 302 on the top, on the left, there is a primary endpoint, the CDR sum of boxes, and the green, which was the high dose of Ajikanumab, showed a 22% decrease in the progression of Alzheimer's disease over the 18 months, whereas the low dose was slightly less. The same trend was, but to a bigger extent, was seen with the secondary endpoints as well on the right. So this was quite promising as a study. Unfortunately, the second study, the sister study 301, didn't have the same results in the high dose. So if you look at the lower dose columns, they had a similar pattern as the lower dose in the 302. However, the high dose didn't show any change, meaningful change in the primary outcome. And this was what first threw the world out and said, this trial and this medication was not going to be effective. And there was an interim analysis in the clinical trial, and as a result, the trial was stopped because it was the futility analysis showed that it wasn't going to have any effect if the trial was to be completed. Next slide, please. The data looking at the amyloid reduction in the brain itself was promising in both trials. So if you can see, the green line was the high dose. In both trials, it reduced the amyloid levels significantly, both over placebo and also over the low dose. Next slide, please. And if you can see here, the difference between the two studies was a time lag in the recruitment of the participants. So one study was recruiting quicker than the other. So as a result, it was more progressed down the line than the other study. And there was a meaningful change done throughout the study. There was a protocol amendment that said that people didn't need that long to wait that long to be titrated up because of fears of getting the side effect of ARIA, because it was less dangerous than they initially thought it would be. And as a result, they titrated people up in a quicker fashion. But because of this discrepancy in the recruitment, in the time frame of recruitment of patients in one versus the other study, one was lagging behind. Next slide, please. So Biogen actually told the FDA that it was the fact that people needed to be on 14 doses of the high dose of the medication in order to be to have a clinically meaningful effect. And if people were lagging behind because of ARIA management or missed doses during the study, they wouldn't have had that effect, and they said that was the reason why the second trial failed. Next slide, please. So the FDA had an advisory committee meeting back in November, and 10 out of 11 of the committee members who were experts in the field said that this medication, Ajikanumab, was not making a meaningful biological effect, and was likely not supporting, and didn't have enough data to support its approval by the FDA. And one participant said he wasn't sure about a possible effect, but none voted positively for Ajikanumab. Nevertheless, Ajikanumab on the 7th of June approved the Ajikanumab. The FDA approved Ajikanumab for Alzheimer's disease, and it was a huge debate in the scientific world. Why would that happen if they didn't have enough data to support the registration? Because the FDA does need two positive results from 2 trials in order to approve any medication. After that, 3 members of the advisory committee resigned, which was a huge issue for FDA, there was very much of discussion of several issues that had happened. So one of them was the actual label. So the label included people with Alzheimer's disease in general, not just with early Alzheimer's disease that the clinical study was about. So it means that if a patient had severe Alzheimer's disease, they could still get the medication. Another issue is that it didn't need the patients to have had any amyloid testing before taking the medication. Recently, after many complaints, the FDA changed the label to give Ajikanumab just in early Alzheimer's disease. And there was also an interrogation into the FDA from FDA itself to look into the approval process and if there was anything that didn't follow the standard protocols. FDA did approve Ajikanumab based on amyloid positivity. So it used a surrogate marker, basically instead of the clinical marker of change in cognition. And it requires a confirmatory trial to be done until 2030. Next slide, please. Okay, so next slide. It is important to think, what does this approval means to us, and does it actually mean we have a treatment for Alzheimer's or not? So it means that future trials will have some problems with recruiting participants. If participants think that Ajikanumab is an effective treatment, they're less likely to enter into clinical trials for possibly even better medications than Ajikanumab in the United States. The EMA is much less likely to approve Ajikanumab based solely on this data. They're more likely to need confirmatory trial before they approve it. And don't forget, this is an expensive treatment, so it costs $56,000 per year, and they haven't really said if this is going to be a treatment just for a year, or is it going to be taken forever. Other agents in the amyloid therapy area, they are testing just for as long as it's needed to reach amyloid negativity. And once the patient has turned amyloid negative, they stop the treatment. Next slide, please. However, Biogen is going to produce a network of imaging that will facilitate future treatments when they come out, and this network will be ready to accommodate all the new patients who are going to seek medical attention, who didn't seek medical attention before due to lack of treatment. Next slide, please. Next. There is an important element of how we are going to diagnose Alzheimer's disease now versus how we did in the past. So it looks like we're going to diagnose the pathology of Alzheimer's disease rather than the dementia. So we are going to try to pick up patients early before they start having memory problems. So by either screening the population or targeting high-risk individuals, and then try to treat those participants preventatively with anti-amyloid or anti-tau treatments. And this is going to make a huge difference in society, especially with the aging population nowadays. It's going to change how we think about Alzheimer's and how we treat Alzheimer's. And the whole ecosystem of the healthcare organization is going to change around this new this new concept. Next slide, please. Some questions that we need to think about is how long do we need to treat with this medication for? Can we find more potent compounds that will need subcutaneous dosing instead of intravenous dosing? That could be given in the outpatient in the doctor's office or the nurse's office, instead of having an infusion suite using Ajikanumab or equivalent medications. And we also need a system to monitor the efficacy of treatment in case a discontinuation is needed, but also in case of side effects. Next slide, please. And my last thoughts are, is this a universal treatment? The answer is no. It will depend in the future which disease stage someone is in. So if they are very early in the disease stage, before they have cognitive problems, they're more likely to get treated with amyloid-targeted therapies. If they have started cognitive problems, but they're still early on, they would benefit more for tau-spreading therapies. And if they're very late in the disease process, they could stick with the symptomatic treatments. However, in reality, it could be that we can use a mixture of treatments like antibodies for amyloid and antibodies for tau to maximize the results. And we also need a good development of biomarkers in order to perform this stratification of patients. I think this is the beginning, just the beginning, the approval of Ajikanumab, but in the future, now pharmaceutical companies have more incentive in order to perform shorter trials with surrogate endpoints. And as a result, they're going to look into more treatments for Alzheimer's disease. And Ajikanumab may only be 22% efficacious in slowing down the disease. However, it could be that future treatments are better in doing that, and the combination of them could be even better. So we are in a good way, but just not there yet. Thank you very much. If you have questions, please can you email this your questions at development events at St. Anne's?
Zoe, that's absolutely fascinating. And we've had some great questions come through already, so please do send more questions in, and I will pose as many as I can to Zoe between now and 2 o'clock. I guess so. Should we start with a very big question that's come in, and that's looking ahead to the future. And someone has asked, where do you see Alzheimer's disease in 50 years' time? Can we eradicate it? How will we be managing it? What do you think the long-term prognosis for society and handling the diseases? I think you're still muted, Zoe, sorry.
Okay, sorry. This is a really good question and a very interesting one. I think out of the neurodegenerative diseases, Alzheimer's is not just the most prominent in the population, but also we are very much ahead in research from other neurodegenerative diseases like Parkinson's or ALS, etc. So I can see the end of the tunnel. So in 50 years' time or so, I think with the development of those new biomarkers, we will be able to either screen the population or after a specific age, for example, or pick up genetic cases with high risk factors, for example, ApoE4 positive individuals, and treat early before the symptoms start. So I think there will, to begin with, there will be an intermediate era when we will have treatments for all different stages of disease. However, in the developed world, at least, we will be able in the future to prevent the disease in high-risk individuals. However, that won't be the case in third world countries, unfortunately. And if the participants do not seek either medical attention or go forward for screening. So there will always be areas, an area for all types of medication, but I think this will shift how we see Alzheimer's disease in the future.
Thank you, Zoe. I'm going to try and combine a few questions in the next one, which I suppose is both on the scientific, the medical side, but also the family, the clinical side of diagnosis. And someone's asked what the shift in clinical diagnosis from the symptom of dementia to the pathological biomarker of the beta amyloid would mean for the treatment of the disease. You know, how reliable is this diagnosis? Should it be coupled with cognitive testing or other forms of triangulation? And I guess that question for people who maybe have a family member or themselves worry that they're showing early signs of dementia, what your advice to those people is too. So a mix of the science and how that should inform how people, family members or potential patients themselves view that early contact with clinicians.
Mm-hmm. Great, thank you. So just to reiterate that this treatment is not yet available outside the US. So at the moment in Europe and Asia, it wouldn't make any difference on how clinicians treat patients with Alzheimer's or even patients with mild cognitive impairment. But in the future, when this and other therapies will be available, I think screening for amyloid would be the first step that the governments will and the public health will have introduced into the screening programs, because at the moment screening is with amyloid PET scans and or CSF collection with lumbar punctures. However, we do have strong evidence that blood tests are able to pick up amyloid positivity in individuals and even tau, phosphorylation of tau. So in the next few years, we'll be able, with a blood test, to find out if someone will likely develop Alzheimer's disease in the next couple of years. And that may not be in the next 1 or 2 years, but it could be in the next 10 or 15 years even. So at the moment, there is no advantage in screening someone for amyloid, especially outside the US. But in the future, even people with family history, before they develop symptoms, it would be best to screen with a blood test rather than wait until they develop memory problems, because that could be too late. And I believe that the longer we wait down the disease process, the less effective the treatments will likely be.
Thank you. Zoe, I guess there's a huge amount of research and money being put into research around the world. Are there drug treatments in the pipeline that look beyond amyloid and tau? And someone else has said, what about a totally different approach, such as targeting inflammation? Maybe you could give us a sense of the different approaches that are being taken and what you think the best bets are going to be for future treatments.
Thank you. Certainly, there is tremendous research around multiple modalities around. Neuroinflammation is a very important one, and we have strong evidence with targets such as TREM2 in Alzheimer's disease, that if we target neuroinflammation, we are going to decrease the risk for developing Alzheimer's and even slow down the disease process, at least in animal models. Other very promising approaches could be to increase neurogenesis. This is really interesting because it was thought until recently that adults do not regenerate new neurons. However, there is research going on that shows that in Alzheimer's disease, neurogenesis is reduced in comparison to healthy individuals of the same age. So increasing neurogenesis could be another option. There is another theory that involves energetics into Alzheimer's disease. So the way that the cells produce energy changes in Alzheimer's disease, diseased neurons, and that could also be targeted for treatment in disease processes, as well as another element of oxidative stress. So there is a multitude of different ways that we can tackle the disease. However, all those modalities have been further behind in the research areas. The first one and most researched is and has been amyloid. That's why we are more, we have progressed more in that area. However, it could be in the future that we use two medications at the same time, one targeting amyloid and the other one neurogenesis, or different modalities in any case.
Clearly, the US have approved Ajikanumab and before anyone else. Do you see that coming to, we know many people here are from Hong Kong, or to Europe, the UK, within a reasonable timescale? Or do you think other treatments will become available in different parts of the world first? When do you think we're going to start to see those breakthroughs? And I guess which clinical trials and where are they? Are you watching with closest interest?
Yeah, thank you. Biogen has been given it has been asked basically to perform a confirmatory clinical trial, a phase 3 trial, to show that the change in the surrogate biomarker is going to translate into a clinical effect. So basically, they have been asked to repeat their clinical trial until 2030 in order to gain full approval, because it has been granted an accelerated approval. According to past precedents, the EMA and MHRA are far less likely to approve Ajikanumab based on those results. And it is likely that they are going to need the extra trial in order to approve the use of Ajikanumab. So I can't see Ajikanumab being used in Europe, UK, or other places in the world in the next few years. It is more likely that other medications are going to be approved first in Europe. There are some well-designed trials behind, for example, with donanemab, even for amyloid treatments, not just for amyloid, but also for tau, but even for amyloid, that I think are going to finish the trials before then. Clinical trials for Alzheimer's disease are run all over the world. I have been running for a few years in London, a couple of them. So it's not difficult to sign up for a trial, and I believe it's important and important for the participant as well, because it's not just a medication that they are trying to see benefit from, but also the fact that they come to the clinic and we have a one-to-one every month. We know the patients very well. They get that social contact with us. And this is very important for the well-being of the patient. So they become less depressed as a result, because depression is a very important element in Alzheimer's. And that familiarity with the staff, the clinic staff, it gives them a big, it's a very big element for them. I think it's important to sign up for clinical trials, not just for the medication in Alzheimer, but also for that social contact for the benefit of the patients.
That is a fascinating point you make there, Zoe, and I guess probably makes all of us who've benefited from the very fast development of COVID vaccines. It reminds us just how appreciative we should be of those people who are willing to be involved in clinical trials right across the board. I guess I'd like to pose you a last very broad question, linking back to the pandemic in a way, as to how that has affected medical research, how it's affected your patients. And I guess also whether you're getting any sense yet. I know there are concerns that the COVID virus may leave a lasting impact on people that we don't understand yet, including neurologically, and whether you have any sense of that yet with your expertise. So very sort of broad, lots of issues related to the pandemic. We'd love to hear your thoughts on that.
Thank you. Yeah, COVID has definitely had a big impact on the research pace, because all non-COVID research at the moment has been dragged behind, which of course is good for COVID research, but for other disciplines and specialties, it has been difficult, really. However, having said that, the people in the labs have been working non-stop during the pandemic, like the healthcare workers have been. So the clock is ticking for finding new drugs for helping patients. So this start of the funnel has fueled us with a lot of compounds to work on, and some of the the healthcare has changed in the sense of how we perform clinical trials nowadays. So even with COVID, we are able to do some assessments either over the phone or with home visits. So it depends on what the trial is about, and it's a new way of life, basically. Like people are working from home nowadays, we have the equivalent new ways of working for clinical trials. Yes, COVID has had a big impact, but it hasn't stopped the trials altogether, and it has given us new ways of thinking about how we can progress research. As for the second part of the question for long COVID and neurological complications, etc., I agree that this is something to think about. It is too early to say what this could leave in terms of brain function, and if that could have any impact in neurodegenerative diseases overall. However, we do know that there will be some kind of long-term impact, and it will remain to see what this will be.
That is absolutely fascinating. And Zoe, on behalf of us all, we'd like to say a huge thank you for your talk and for answering our questions. It has been fascinating. And also express our gratitude to you and your colleagues who are working in such an important area that I think probably touches all our lives in different ways in terms of people we know or care about, or anxieties for ourselves for the future. So we're very proud of the work that you and those you work with are doing. I'm delighted that you continue to support the college, the Centre of Personalised Medicine, and on events such as the summer school this week. So thank you again, everyone, for joining us. We hope you found this interesting. If you look online, you may be interested in some of the other talks and events that we have posted that you can find via our website. And please do keep in touch with St Anne's College and our news. And thank you again for the support that you've given us, and we hope will continue to give us in the future. We hope you enjoy the rest of your day. Goodbye.